Hi, everyone. So, after Joe and I talked today about testing in cancer, I know it was quite a whirlwind of information and lots of things were thrown at you. We also didn't manage to answer a lot of the questions. So, what I wanted to do was trying to answer some of the Q&A and maybe talk you through a little bit more detail on some of the things that were asked. So, excuse me while I look to the side. I'm going to be looking through the document that has the Q&A from the talk. And then we'll go from there. So someone asked, can I have a blood test that shows if I have active or live cancer cells in my body rather than just relying on scans? If you've had cancer before, then there is, and you've been known to have circulating tumor cells, we can do a test, something like Biosept or another liquid biopsy, to look for circulating tumor cells and to also look at the different mutations. Now, those tests are not validated for absolutely every cancer, so you need to actually have a look at what's validated for your particular type of cancer and do that particular test. How does one monitor for recurrence? I know we've discussed a little bit, but I think I wanted to reiterate the importance of the fact that you need to look at your whole physiology. The best way to decrease your risk of recurrence is to support a healthy body, a healthy immune system, and your overall well-being. How to monitor will depend on what your particular cancer type is, and it can involve imaging, it can involve tumor markers, and it can involve looking at some of the other blood tests. So it's very, very cancer type specific. It's very difficult for me to answer fairly general questions because cancers are so different. Correct neutrophil to lymphocyte ratio. There are a number of different cutoffs in the literature, but usually we use anything between under 2.5 or under 2.2 would be a good neutrophil to lymphocyte ratio to have. Some people use slightly lower cutoffs, so under 2, for example. I think that neutrophil to lymphocyte ratio is more of a graded thing rather than yes or no answer. So I would say they're probably least risk when you're under 2 in terms of chronic inflammation. Then between 2 and 3, you're probably at more intermediate risk. And as soon as you go above 3, you're probably at really high risk of having a lot of systemic inflammation. Then is the test for circulating cancer cells useful for diagnosis and for follow-up for recurrence or monitoring treatment response? So that's an interesting test. I don't think that we are there to use circulating tumor cells as a diagnostic tool per se. I don't think there's been a validation for that as far as I know for a number of cancers. Can we use it for monitoring treatment response? I think that there may be some evidence coming out around that, and I would certainly use that in my clinic for seeing what changes occur in terms of circulating tumor cell burden and how the cancer responds in terms of mutations as well. And evidence of recurrence, it can be used for specific kinds of cancer, but it's really important to never use one test alone. It's the whole picture that counts. Are there any tests I should be getting done myself on a regular basis in remission? I think it's always good to know what your full blood cell count is. I think it's always used to know that if you've had tumor markers before, it can be useful to follow them to make sure you're not trending upwards. And making sure that in terms of your history and your overall well-being, you've got your life where you want it to be. And that's where Joe and I discussed testing the wider aspects of your physiology to make sure that you are in good, healthy balance. New to integrative medicine as a cancer patient, what are the most important functional medicine to start off with generically? That is very difficult to answer. The way that I use testing is to help me make those decisions in clinical practice. So I would look through someone's clinical history to help me decide. In breast cancer, for example, because that's what my area of specialty is, I would quite often prioritize during treatment tests. So for example, making sure someone has, full blood cell counts, liver and kidney function, their LDH measured, their inflammatory markers measured, including ferritin, and ESR and highly sensitive CRP. And then I would look for the functional test really in terms of nutrigenomics, looking at estrogen detox particularly. And then as well as the wider markers, so having a look if someone can methylate properly. That means to be able to get rid of estrogen in an effective way. I would also potentially look at the Dutch test, and we'll discuss it in a second, a bit more detail. But I would look at that to, if someone is not on hormonal treatment or before they go on it, to see what is happening with their metabolism. So they're kind of some of the starters for 10 in breast cancer. I'd also look at general nutritional status, which is important. And sort of go from there. If someone's had a lot of antibiotics in their history, if I'm concerned about their gut microbiome, I would look there. It is very, very dependent on what kind of cancer you have, so what the drivers for that physiologically are, and also what your clinical history points us to. What has created that environment that didn't allow our normal anti-cancer defenses to kick in effectively? Personalized medicine, tumor culture, sensitivity testing has gained traction in the mainstream. Can you comment on personalized medicine and its resistance in the mainstream? I think personalized medicine has come into cancer therapy pretty well in oncology, actually, from the drug point of view. So these days, we, for example, test colorectal cancer for subtypes of KRAS, and that will help us decide what to do with the patient. We will look at, of course, subtyping for breast cancer, and we will look at some of the personalized risk scores, like Oncotype DX, to decide what to do with patients. But in terms of personalized medicine, wider than the drugs, I think that's where it has not come into the mainstream, and I'd like to see us address that. In fact, in a paper talking about the hallmarks of cancer, Hanahan and Weinberg, the two big scientists that talk about the molecular biology of cancer, they say that the way we look at cancer should be trying to defeat it from all 11 hallmarks. But then in the same paragraph, they say that we can't do this with drugs because the patient would not handle the toxicity. So what I would say is, why not look broader? Why don't we just try and look to integrate everything we do medically, the best medical practice, but also the best practice in terms of, can we look at some other options to target the other hallmarks of cancer, non-toxic options, to try and make sure that we cover our bases really well. How to build low hemoglobin after chemotherapy. So it very much depends on what's going on with you. There are some general bone marrow support things that you can do. I usually use herbal medicine for that, but herbal medicine is highly individualized, and we can't really talk about it without knowing what your background is or what medications you're on. In general, making sure you have excellent nutritional status, the fact that you've got an anti-inflammatory, high phytonutrient diet, which I'm sure Taral and a colleague talked about anyway, that is absolutely crucial after chemotherapy and during chemotherapy as well. Raised platelets is early non-specific marker of cancer. I mean, platelets can be raised by so many things. If you've got an infection, it can raise your platelets. There are a number of things that can affect platelets, so I wouldn't jump to conclusion. It is too non-specific. However, if I might see someone's rising platelets, rising LDH, maybe rising tumor markers, and together they give me a high index of suspicion that there is recurrence lurking here. We talked about ferritin. Then let's have a look. How often should tumor markers be repeated, and should the blood test be done? So if you're on active treatment, you usually will have your blood test before any rounds of chemotherapy. After chemotherapy, that's quite often when monitoring can stop a little bit. And actually, I would definitely get your blood test done, 2 to 3 months after chemotherapy, to have a look at your white cell count, kidney function, liver function, nutritional markers, and inflammation markers, to make sure that you've got a really good baseline to assess where to go from there. And LDH is useful. So we didn't get a chance to talk about it because we only had 30 minutes and we had a lot of ground to cover. But LDH is, and particularly LDHA, is very useful in cancer. Now, we again look at not a one-off number, but at a trend and whether it's trending upwards or downwards. We also look at very specific subtypes. So LDHA or isotype 5 is important because that's usually more of a malignancy derived type of LDH. And LDH is important because it actually changes the tumor microenvironment to become more pro-inflammatory and less supportive of effective anti-tumor response by your immune system. And we don't want this because actually having a really high LDH in the tumor and having high lactate in the tumor microenvironment can engender therapy resistance. It can support your tumor becoming more resistant to chemotherapy or other therapies, including targeted ones. How often should tumor markers be repeated? It depends on where you're at your phase of treatment. Certainly, if someone's finished treatment, I would, for the first year, probably repeat them every 3 months and then every 6 months to annually, depending on where you're at. I wouldn't try and run them too close together because it's very, very difficult. If I'm monitoring someone really closely because their cancer situation is quite unstable, I might run them closer than that. I might run them every 6 weeks, for example. My oncologist hasn't been able to answer any of my questions regarding gene mutations or mineral deficiencies. Do I need to go private? And is Nuffield the best place to go in the UK? So your oncologist has an incredibly big job trying to keep up with a whole ton of research on conventional therapies. We cannot expect our oncologists who are working really, really hard to try and be an expert in everything. They can't be. That's why we need to have teams and care teams. So I would suggest trying to find a good integrative doctor or a functional medicine practitioner who's experienced in cancer specifically to discuss that, to discuss genetic SNP testing and to discuss some of the other testing if you have wider concerns. And then they can communicate with your oncologist as needed. And I wouldn't think the Nuffield has the best access. I would suggest actually finding the right practitioner first. Because whatever test you run, it's the interpretation, the plan that comes out of that that's the most useful thing you're going to have. Is it worthwhile having lipids done post-chemotherapy in hormone-related cancers? Yes, absolutely, but you need to leave it a little while. And I generally monitor lipids in any postmenopausal woman at all, including my breast cancer patients, to make sure that their lipids are good, because postmenopausally your risk of cardiovascular disease increases anyway, and it's a very real danger in terms of morbidity and mortality at that age group. So yes, I would say absolutely. Targeted therapy was not discussed. Well, I couldn't discuss therapies. This was a session on testing, so I'm sorry we couldn't discuss targeted therapy. Does antioxidant and mitochondrial support also enhance and promote diseased cancer cells? Again, this is a session on testing, so I can't go into that in a lot of detail. What advice would you give to people whose lymphocyte counts is low 2 or more years after treatment for cancer? Come and see an integrative health practitioner and get your nutrition, lifestyle checked out. Quite often we use a set of herbs. For example, astragalus, I use medicinal mushrooms, and I will use some of the other herbs to try and bump people's lymphocytes up, but not just that, look after their whole immune system. So I've mentioned a couple of things. Please check in for your specific case because it's really, really important. Let's talk about the Dutch test. So I'm going to share my screen and then you and I can talk through it. So this is what the Dutch test report looks like. So when we look at it, it will give us on the front page, a quick summary. It will talk about your cortisol, which is your stress hormone, and it will talk about the sex hormones, which are estrogens, progesterone, and testosterone. So the important bit of Dutch isn't just this first bit of looking at the relevant hormone levels, but it's also looking at how you break down your estrogen. So if I go to the next page, and this is a very complicated diagram, but I'll talk you through it. So when we make estrogen, we have to break them down, and we can break them down via 3 different pathways. The green one is the protective one. This blue one is not so good, And this red one is also really quite dangerous. So when we have more estrogens pouring down this red pathway and we can't detoxify them effectively, we will need to be careful, because that can actually bind to and damage DNA. Sorry, a little interruption. Right, so what's important here is looking at the relevant different ratios between the different pathways. And the specific things that we can do nutritionally that can try and modulate that ratio. For example, if you have too much going down the 16 pathway and too little going down the protective 2 pathway, we can use things like nutritional intervention like broccoli sprouts or cruciferous vegetables to try and shift that ratio. And I've seen it done in clinical practice a number of times. We can also use some of the supplementation stuff like DIM, which is again derived from cruciferous vegetables. CYP1B1 is another enzyme that can be effectively inhibited by a number of natural substances to try and modulate metabolism. And of course, the other thing we can always take care of is this detox pathway down here called glutathione, which again, there's specific nutritional modulation stuff for. The other thing the Dutch test does give us at the very end as well is some of the nutrition markers. So we'll look at B12, B6, the detox, and some of the neurotransmitter markers. So as you can see, it's quite a comprehensive test. I don't ever use it alone. I use it in combination with other testing, but it can be very valuable. Right, let's answer a couple of other questions. So how do you know the practitioner uses the right test and from the right lab, as the patients don't know? That can only trust the practitioner. I understand it's very tricky, but this is where it's important to do your homework. When you pick a practitioner, ask them some questions, but also have a look at their bio. Make sure they have cancer training listed as part of their expertise. So that's what you'd want to know. You'd want to make sure they've got enough education and background behind them to recommend the right test for you. Is there any way that would simplify the subject? I wish there was. The most important way of simplifying this is to try and just stick to first the test that your NHS oncologist or your GP can do for you. So optimize the ratios there, optimize your vitamin D, making sure you've got enough B12 and folate, making sure you've got a general fantastic anti-inflammatory diet with a bit of intermittent fasting thrown in ideally. And then if you are ready to look at it specifically, go and find a partner. It is really important to find an educated practitioner who will be your partner through this. This testing field is very complicated, even for people who have been in this industry for a long time. So don't feel like you have to know everything. Just take your time and do it one step at a time. Anyway, I hope you've enjoyed the additional video, and thank you. Bye.